All right, so it's so good to see everybody here. My name is Brittany Sharp McCollum. I own Blossoming Belly's Holistic Birth Services based out of the greater Philadelphia area, Philadelphia, Pennsylvania area. I teach childbirth education. I do pelvic biomechanics trainings for clinical and non clinical birth workers. I do lactation support and webinars as well. So we have monthly webinars. Usually the paid webinars include contact hours. So you can find recordings of those on the website and get contact hours if needed. I also like to do these free webinars. I try to do them every 6 weeks or so, but as you can see, I recently had a baby, so have not been as on point with doing the free webinars as I'd like to, but I plan on getting back into that now. There's a bunch of them on the website too, so you can find them on there. You can refer clients to those if you're a birth worker attending. The webinars are really fun. So we do them every month. Sometimes it's me facilitating, sometimes we have guest speakers. And the free ones are always me facilitating. They're really an opportunity for a deep dive into topics that sometimes get skimmed over a bit in childbirth education classes. I know in my classes, I'm always trying to pack in as much information as possible and trying to sort through what seems most relevant. But sometimes that means that topics that I really want to explore in depth, we don't always get to cover. So the webinars are kind of a way for me to also go a little bit deeper into lots of topics that I want to explore more and that I think are really important for people to understand. So thank you all for joining today. Today we're going to be talking all about the pushing phase of labor. We'll be sharing tips to keep pushing as efficient as possible and also to really restore autonomy to the person giving birth and understand what the research says about well-being and the way that we push in labor and how that affects our long-term health. So we'll be looking at that too. So I have slides, but we'll also be getting up and moving a little bit, which you are welcome to do as much or as little as you'd like. As with all of the webinars and classes and everything that I do, here we go. There we go. With everything that I do, I encourage you to be as involved as feels good to you. If I'm asking you to do something that does not agree with you today, then don't do it. If I'm asking you to do something that you know is not really feasible for your body, don't do it. It's just a suggestion. You can modify. I'll often give modifications so that people aren't feeling like, oh, I don't know what to do now. But you could also just kind of sit and watch. That's fine too. But I'll be demonstrating some stuff today. We'll be getting up and moving a little bit. I like to keep all of my workshops and stuff interesting enough that, like, you know, we're getting up, we're moving, we're not just sitting there and listening to me talk for an hour or however long. So today we're talking about practical pushing, efficiency and well-being in labor's second stage. So here's my little disclaimer. Please remember that the information provided in this presentation is for informational purposes only. I am not in a position to diagnose situations. I do not provide medical advice. And if you are attending as a birth professional, it is your responsibility to utilize this information within the scope of your practice. I also ask that you don't reproduce or share the slides in any way, or reproduce or share the photographs that are in the slides in any way. All right, here's what we're going to cover today. We're going to understand the physiology of the second stage of labor. So before we even dive into how to make the second stage of labor more efficient and more positive, we're actually going to talk about what the second stage of labor is. I think it's really important for all of us to be on the same page in terms of our foundation of understanding, and that begins with even just figuring out what the heck is the second stage of labor. We're also going to explore parental positioning as a factor in pushing. We're going to compare open and closed glottis pushing, and we're going to contrast directed and spontaneous pushing. So those are the three main aspects that we are going to look at in terms of how we can improve the pushing experience for people giving birth. We're going to look at positioning, we're going to look at open and closed glottis pushing, and directed versus spontaneous pushing. And then we're going to prepare for the pushing phase of labor through developing familiarity and awareness in pregnancy. So whether you are joining today as a pregnant person or as a birth professional, you can totally use this information. If you're a birth professional, we're going to go over an activity that you can share with your clients, you could do with your clients. And of course, if you're a pregnant person, you can do this exercise that we'll do together every day from here on out until the birth of your baby. So I will talk a bit more about how to utilize the information that we're going to be discussing, regardless of what your role is, parent or birth professional, or maybe both. So let's dive in. So here is my little chart of the second stage of labor. So let me first share a really brief overview of what the first stage of labor is. So the first stage of labor is when the cervix, which is the opening to the uterus, is thinning, getting shorter and shorter, and dilating, getting more and more open. The first stage of labor is pretty much all about change in the cervix. The first stage of labor includes a little bit of the baby's descent and a possible rotation as well, but mostly the first stage of labor is all about the change in the cervix. The second stage of labor is primarily about the descent of the baby. We tend to think about the second stage of labor as being all about pushing, right? I mean, that's what you guys are here for today, to learn about pushing. But I can't stress enough the importance of the resting phase of labor. So the resting or latent phase in the second stage comes before pushing. And for those of you that have attended births, you've probably seen this happen, where someone reaches full dilation, but they're not yet ready to push their baby out. They might be feeling a ton of rectal pressure. They might be talking about that rectal pressure. They might be talking about what they're feeling, but they're not inadvertently, spontaneously, involuntarily bearing down. They're still talking about it. They want to bear down, but they're not quite there yet. That's the resting phase. That resting phase is crucial because it allows the baby to descend out of the uterus and move lower into the vagina and the pelvis. This is really important because, let me stop my share for a second. Here in the middle of the pelvis, we have these bones called the ischiospines. And as you can see, maybe seeing from here is a little bit easier, these ischiospines jut inward at the middle portion of the pelvis, what we call the mid-pelvic cavity. So as the baby is descending and rotating and making their journey through the pelvis, the baby has to work their way down between those bones. And that happens sometimes in transition, sometimes during this resting phase of labor. But here's the thing. If somebody begins pushing simply because the cervix is open, not because the baby is actually low enough in the pelvis to have passed by these bones, then we wind up with a baby who may have the wider part of their head trying to fit through this narrow space of the pelvis. And if we are bearing down, pushing with everything we have, with a baby that is not lined up to move easily past that narrow part of the pelvis, then we often wind up in a situation where we're pushing and pushing and pushing forever, and there's not a whole lot of progress. Or we wind up in a situation where the baby's head is getting compressed and we see dips in the baby's heart rate, which starts to put a little bit of a time limit on the amount of time somebody's given for pushing. Sorry, feeding a baby here too. There we go. So we see either a long pushing time, or we could see increased risk of distress in the baby if we are pushing when the baby's not yet past that midpoint of the pelvis. And the baby descending out of the uterus, rotating past those bones, is what's happening during that resting phase of labor. So respecting that resting phase before pushing is really important. Sometimes there might be a situation where it makes sense to push before the baby is past those bones. You know, maybe there's a need to get the baby out quicker and it's like, we need to start pushing now for, you know, whatever reason. But the number one question to ask, in my opinion, is if you're a birthing person, is, am I fine? Is the baby fine? Because if I'm fine and the baby's fine, let's wait a little bit. Let's wait till I'm feeling that undeniable urge to start bearing down. So that resting phase is really important, and I want to give it the time that it deserves to really discuss it and understand what's happening there. So that is really that time that the baby is descending out of the uterus and getting into a more ideal position for pushing, which means rotating past those spines. Now, in that resting phase, you can see contractions are fairly far apart. They're short in length. There's a lot of rectal pressure, but people are not involuntarily bearing down. There is grunting happening, specifically at the peak of contractions, but people are full on able to fall asleep in between contractions at this point. So this point of labor, I think, again, is really important to understand, but that's not going to be the emphasis of what we're talking about today. What we're talking about today is the active or pushing phase of the second stage. This is what we see in the movies, right? Pretty much all of labor looks like pushing when we're watching a movie that has a labor scene. But as anyone knows who's given birth, usually the longer part of labor is that first stage of labor. The pushing phase on average for a first-time parent is about 1 to 3 hours. The pushing phase of labor can be a little bit longer with someone who has an epidural. It can be shorter in someone who's having an unmedicated birth, but it is not a guarantee to be longer with an epidural and shorter with an unmedicated birth. There are other factors that play into that too. But this active or pushing phase of labor is the last part of the second stage. It is when you're bearing down to push your baby underneath the pubic bones here, and then it ends with the birth of the baby. So that active pushing phase of labor is bearing down to birth the baby, ending with the baby being born, baby's now out and in your arms. So we have spontaneous or directed pushing, which we're going to go into more in depth. We have closed versus open glottis pushing, which we're going to go into more in depth. So you can kind of ignore those areas just for now. We're just trying to get an understanding of the physiology of the pushing phase. But we will talk about those obviously today, because that's what you're here for. What we are doing during this pushing phase of labor is bearing down. We use this term bearing down a lot. I know in birth classes we talk about bearing down a lot, but it's really important for people to understand what that means. Because if we're just using this lingo and somebody, has never learned about birth before, they're like, I don't really know what bearing down is. Bearing down basically means you're kind of pushing like you're pooping. Ideally, not really like you're constipated, because we know the pushing that somebody does when they're constipated is not really optimal for the pelvic floor muscles. It's not really optimal for oxygenation, but we're thinking about that same sensation of needing to push out a bowel movement, and it is the same area that's working when we're pushing out a bowel movement. And the muscles are actually working in a similar way when we're bearing down to pass a bowel movement and bearing down to birth a baby. It is also really important for people, especially those that are going to be giving birth soon, to recognize that you're not pushing for 1 to 3 hours straight. I mentioned that that's the average. You're not bearing down for 1 to 3 hours straight. You're only bearing down with contractions. And contractions at this point are about 3 to 5 minutes apart, and they're about 45 seconds long. So you are getting a nice break in between those pushing contractions. This gives you an opportunity to rest, maybe even sleep for a minute or two. It gives you an opportunity to change position. It gives you an opportunity to get something to drink, or maybe even something to eat if you're feeling it. It gives you an opportunity to have a support person wipe your face down with a cold cloth. So this resting phase is really important for giving you the energy to keep going, for helping you stay comfortable so that you feel like you can keep going. It is not 1 to 3 hours of straight up pushing. That would be crazy. Instead, we're pushing only during contractions. When you are pushing your baby out, it is like 2 steps forward, 1 step back. So again, let me stop my share for a minute. Here's baby's head coming through the pelvis. Baby comes down with the push a little bit further, and then the baby comes back up. And then next time you push down a little bit further, maybe a little bit further, and baby comes back up. Most of the time that people spend pushing is actually just rocking the baby under the pubic bone, which we think, oh my goodness, that sounds crazy, right? Why can't we have more progress? No, think about this as a really great way that your body helps to protect the pelvic floor muscles and protect the perineum. I love in my classes, I love to point out the ways that our bodies naturally preserve themselves through challenging experiences like childbirth. And there are so many protective mechanisms in place during the laboring process. And this is one of them. That 2 steps forward, 1 step back allows the baby to slowly emerge. It means not too much pressure all at once on the pelvic floor. It means not too much pressure all at once on the perineum. It means that we could potentially decrease the risk of tearing if we respect this rocking process of allowing the baby to come down and back and down and back. So as we mentioned, contractions at this point are about 3 to 5 minutes apart. Whoops, sorry guys. I want to make this bigger so you can see it more easily. There we go. They're about 3 to 5 minutes apart, 45 seconds long, lots of rest time in between. The discomfort is pretty much all in the bottom, right? And when we say bottom, like it's pretty much all in your butt. That's what we're talking about. Overwhelming rectal pressure. Think of it like this. I did a consult recently, and this came up in discussion. Actually, it was not me that made this analogy. It was the partner, and I thought it was so great. So I'm totally giving him credit for that. I did not come up with this, but he said it's like this. It's like going to sit on the toilet because you have to pee or have to poop, and you're like, I'm gonna just wait because I know it's coming, versus, oh my God, I need to get to the toilet right now because I'm about to poop my pants. That's the difference between, yeah, I feel a ton of pressure and I could push, versus like, my body is pushing right now. It's like, yeah, I think I have to poop, so I'm going to go hang out in the bathroom for a little bit and go on Facebook or whatever, right? But the alternative, which is kind of what we're aiming for in labor, is like, oh my gosh, I have to poop right now. I better make it to the bathroom. So that's what we're thinking about, this overwhelming rectal pressure that leads to spontaneous pushing. And again, we'll talk about the difference between spontaneous and directed pushing in just a bit. So this is kind of your overview of that second stage of labor. Important to have this kind of foundational information first so that you know what we're actually talking about as we get into different positions and as we start exploring things like directed versus spontaneous pushing and open versus closed glottis pushing. So let's get up and move. So as anyone who's taken any of my workshops knows, I love to incorporate movement because it's really boring to sit for a long time, and it's really not good in pregnancy to sit for a long time either. So whether we are modeling behavior for our pregnant clients or whether we are needing to move ourselves, it's always a good idea to get up and shift a little bit. In pregnancy, really, I would say, like, don't sit for more than 20 minutes at a time. Get up, stretch, move, rock your body. So if you want to get up with me, you can. The reason that I want to get everybody up and moving a little bit, besides the fact that it keeps you guys energized, is that I want to go over a little bit of pelvic dynamics. I can't help myself. I love talking about the pelvis, so I gotta throw it in there. But it's really important, actually, to in understanding pushing positions, to understand how we open up space at the bottom of the pelvis. So I'm not going to go into like 30 minutes of pelvic dynamics. I just want to give you enough so that you understand what we're aiming for with the pushing positions. But I also want to emphasize that if you hear this information and you're like, I don't understand, I have a lot of resources about why certain things open the pelvis in different areas, both free resources on my social media and then a lot of webinars that cover that too. So you'll kind of have to just trust in some of what I'm telling you. But if you are interested in more about the why, there's a lot of stuff, a lot of resources available on my website and social media for that. So when we're talking about pushing a baby out, the baby's down here. So the baby is not up here hanging out at the top of the pelvis. When we're pushing, the baby is down here. And so what we want to focus on is opening that part of the pelvis, that bottom portion of the pelvis. So in order to open the bottom portion of the pelvis, we need to do positions that do this and positions that do this. And maybe also positions that do this. Especially if we have a baby whose head is tilted to the side or baby who has their hand up by their head, then we want to make sure that we are getting into positions like this as well. But really we're aiming on opening side to side space, opening front to back space, and also throwing in some diagonal space changes as well. So we need to understand how we do that. How do we open side to side space at the bottom of the pelvis? How do we open front to back space at the bottom of the pelvis? How do we open or change diagonal space midway through the pelvis? Here's how, and this is where you might have to like trust me and then go find the other resources that talk about all the research that supports this, because this is going to be a little bit different than what you see in the movies. In order to open space here, we need to do this. When the thighs internally rotate, let me move my pelvis here. When the thighs internally rotate, the femurs, the thigh bones, pull out on the hips, and this happens. So the thighs coming together open space side to side at the bottom of the pelvis. I know this is the opposite of what you see in the movies, and it is the opposite of what people are told to do in labor. But from a biomechanical standpoint, when we bring the knees together, we open space side to side. What we see in the movies is, and in real life often, is people pushing with their knees as far apart as possible. When the knees are pulled as far apart as possible, we have what's called external thigh or external femur rotation. That pushes in at the hips, and this happens. We get more space at the bottom of the pelvis, side to side, when the thighs are internally rotated. Sometimes we call that closed knee pushing. So if you've come across closed knee pushing before, this is what we're referring to. Internal thigh rotation, the thighs coming together, which opens space side to side. So as we look at pushing positions, those are many positions that we're going to be taking a look at, positions that actually bring the knees together. So that's the first part of pelvic dynamics that's important to understand. And if you want to get up with me for a minute, you don't have to, but if you want to, you can feel the difference between bringing the knees together or bringing the thighs far apart. One way that I think is really helpful for people to feel that difference is to put all your weight on one leg and then rotate your thigh out, bring your thigh in. Sometimes you can feel that movement a bit more easily when we're focusing it on only one side of the body. So what's happening is this. My thigh externally rotates. My thigh internally rotates. External, internal. So we're thinking about that as we explore different pushing positions because we want to make sure that the positions that we're in are creating as much space as possible for our babies. Notice when we widen side to side space, we actually get a ton of extra space back here by those ischial spines. But look what's happening too with that pubic arch. It's getting a lot wider, which means for a baby who might be positioned like this, or a baby whose chin might not be tucked, but instead maybe their head's extended a little bit, or a baby that's presenting with their hand up by their head, they might need that extra 1 to 2 centimeters of space. They might need that extra wiggle room at the back of the pelvis. They might need a wider pubic arch. And so when we focus on positions that open that side to side space, we allow babies who might be positioned a little bit differently than what might be ideal to have that ability to still descend and come out. If we were in positions that only decrease space, the baby's gonna have a much harder time making their way down and out. One of the things that I love to emphasize to people is the importance of changing position frequently, not staying in any position for more than a couple contractions, because even if we're in a position that's like creating all the possible space, the baby is still wiggling their way down and out. And if the baby's not given changes in space to work with, then it's going to be a lot harder for the baby to work their way out. Even if they have a lot of room, they need changes of space as well because they are literally incrementally working their way out. They're actively involved in the process. So side to side space is increased by internal thigh rotation. And we will look at how that applies to specific positions in a bit. Then we also want to think about how to get that front to back space. How do we get that lower portion of the sacrum to open out? The number one thing is to make sure the sacrum has freedom to move. So the sacrum should not be flat on the bed. Then the sacrum doesn't have the ability to move. Interestingly, this is a side note, but I feel like if I don't explain it, then I'm missing a key part. So I'm going to explain it even though it's kind of tangential. But here we have the sacrum flush up against the bed, right? The sacrum can't move. We can get movement by lifting these bones up. These are called the innominate bones. If we tip the iliac portion of the innominate bone back, we can still get more space. And that's what happens when somebody's legs are hiked back towards their ears. Those bones are pulled back. So when somebody's lying on their back, like what we see in the movies, somebody's yanking a leg, hopefully not yanking, but holding a leg way far back by the ears. What's happening are these bones are actually being pulled up, which does create the same space change as the sacrum moving. But when those legs are pulled all the way back like that, that is not a position that people get into naturally. That can cause a lot of hip discomfort. It can cause a lot of low back discomfort, and that position will not protect the pelvic floor or the perineum. But if we're in positions where the sacrum moves, those positions will protect the pelvic floor and the perineum. So even though we can get a space change like this, we get more benefit with letting the sacrum be the thing that moves, not the innominate bones. So I'm throwing that out there. It's a bit of a tangent, but I think it's important to point out, especially when we're talking about why people still can push babies out when they're in a position on their back with their legs hiked all the way up. With the legs pulled all the way back like that, you do get space change, but it's not ideal for other reasons. So front to back space is changed in the pelvis by allowing that bottom portion of the sacrum to move. It needs the freedom to move. The baby's head will push the sacrum out of the way, but we can also get into positions that further increase that ability of the sacrum to move away from the pubic bones. And that's what we're going to take a look at. The third thing that I just want to point out, those diagonal space changes. We get those diagonal space changes by doing something on one side of the body and not the other. So what I showed to you before, this movement is a really great example of that. We're doing something on one side of the body and not the other. So as I showed you before, we're getting diagonal space changes. Something else we could do, if you have a chair or something next to you, one leg up on the chair. So a lunge position, that's going to also change space on one side of the body. If we lunged with a leg in front of us, that's going to change space on one side of the body. So doing something on one side of the body, not on both sides of the body at the same time, is going to create that diagonal space change. What is a really super simple way to get diagonal space change in the pelvis? Walking. This is why the labor dance is so awesome, because with the labor dance, you can do it at any point in labor, and it's this side to side rocking, maybe a little bit of walking like you're slow dancing with somebody, and that's all about that asymmetrical movement. So the labor dance is such an easy thing to apply to any part of labor, and it's going to help create those diagonal space changes in the pelvis. So when we're talking about opening space specifically at the outlet, which is what we're talking about with pushing, so the bottom of the pelvis, that's where the baby is, that's where we want that space. We focus on creating side-to-side space by bringing the thighs together. We focus on letting the sacrum move by freeing it up, not having the sacrum flush up against the bed. And we focus on diagonal space changes by doing something on one side of the body and not the other, whether that's rhythmical, like the labor dance, or whether it's more stagnant, like a lunge position. So that's what we're thinking about in terms of how we're opening that space or changing that space at the bottom or the outlet of the pelvis. So let's move forward. And as I mentioned before, if anybody has questions, put them in the chat. That way, if I do wind up answering them as we go, that's awesome. If not, at the end, I will go through the chat and see what questions seem probably most relevant to everybody. And then I will make sure that I answer them. And any questions that I don't answer that are in the chat, I'll do my best to remember them and answer them in the follow-up email. Everyone will get this recording sent out to them. So everyone who is signed up, attending live, you guys will still get the recording sent to you. So I can do any answers to any questions in the follow-up email too. So let's move forward. Here are some of our positions that we're taking a look at. So much good stuff here. Lots of positions here that are utilizing the internal thigh rotation or closed knees. Well, actually one position here that's three positions that are utilizing that. I'll point them out. We also see freedom of movement of the sacrum, right, in every single one of these positions. That seated position on the bottom left still allows for sacral movement. If she was reclined or semi-reclined, then we don't get that sacral movement. But sitting upright, that sacrum can move. It's like the difference between sitting upright versus slouching back, right? We don't want to be slouching back, then all the weight's on the sacrum can't move. And then we also see asymmetrical positions here too. So we have a standing position. This obviously you can see that arch in her lower back. That's really allowing for that sacrum to move out of the way. We have the seated position on the bottom left. This person's in a birthing tub. Look at what she's doing with her thighs, right? So her thighs don't have to be together. They just have to have internal rotation. And if we bring the ankles farther out than the knees, the thighs automatically internally rotate. And this person is doing this without any direction. This is the position that felt good to them when they were birthing. So I think that's really, really awesome to point out. We also can see in the top middle, this person is in a staggered leg, forward leaning position, and she actually has her ankles slightly she has her ankles slightly outwardly rotated as well. So she's got a little internal rotation with her thighs, and one thigh is in front of the other as if she was kind of crawling on her knees. So a staggered leg position is a great option for asymmetrical pushing. Then we have this picture. I'm going to use my cursor over here. This is actually a friend of mine. I love this picture. I think it just shows so much power. She is on all, kind of on all threes, leaning on her arm, but also on her knees. Although she has that external thigh rotation, which is not opening space at the bottom of her pelvis, She's got total freedom of movement of the sacrum. And this is an unmedicated birth. One of the things that I emphasize with my clients that are unmedicated is, well, with all my clients, but specifically when there's full sensation, your body knows what to do. If I'm like internal thigh rotation all the time and they're like, no, that doesn't feel right, then we don't do that. We emphasize that the person who's laboring knows best what they need. So maybe in this position, maybe she needed more narrow space side to side, but she's getting that opening front to back. So depending on how the baby is positioned and moving through the pelvis, if we have full sensation, we want to listen to that first and foremost. The biomechanics is awesome to apply, especially if somebody needs guidance. But if somebody's like, this is what feels good to me right now, we need to make sure we're respecting that too. And frequency of movement, again, is really important. Then we have down here at the bottom, this awesome picture. This person is using deep asymmetrical positioning on a squat bar in the hospital with an epidural as a VBAC. So awesome. VBAC is vaginal birth after cesarean. And the reason that I get excited about this and say so awesome is not because I'm trying to set the bar for everybody to have a birth like that, but because this person took their knowledge and information and applied it in a way that was empowering for them. And I think what it really comes back to with birth is being in control of the decision-making process. And this person did that. They chose to have a VBAC. They chose to get an epidural. They chose to still advocate for being upright. They chose to request the props in the laboring room, like the squat bar. Just lots of advocacy in that. And I think, not only I think, but what research tells us is that when someone is more actively involved in the decision-making along the way, they feel more positive about their birth. And that's a really empowering experience. So great asymmetrical position here. That I think is just, awesome to point out. So these are great pushing positions that utilize asymmetry, possible internal thigh rotation, and freedom of movement of the sacrum. The reality, though, is that the majority of people birthing in our country do give birth on their back. And if birthing in an upright position is not a top priority for you, then maybe you want to know what you can do if you're still reclined. So here are some options, right? Because it's all about options. It's all about feeling like you know your options and are confident to advocate for them. So here we have reclined positions. The top left, we actually used a pool noodle, but you could just use a rolled towel to put it under one butt cheek. So all that does is free the sacrum, right? Now the sacrum has a little wiggle room. So we've taken a reclined position and we've freed up that sacrum. And this is something that I've done in a lot of births with providers not even realizing. Just a rolled towel under one butt cheek. The pool noodle is great because it holds its shape a little bit better. So if you're a birth worker and you want to bring like a maybe 10-inch section of a pool noodle with you, I think it's a really great prop to use with clients in labor. But if you bring it and give it to the nurse, if you're like a pregnant person, I don't think the nurse would exactly know what to do with that. You might have to instruct or guide them with that. Then we have, if you go diagonal down to the bottom right, we have another reclined position, and this is with a reboso rolled underneath the lower back. What are we doing there? Creating that arch in the lower back that allows that sacrum to move. So same thing, we've freed up the sacrum. We've allowed that sacrum to move, which gives a little bit of additional front to back space. Now in the other two pictures, the top right and the bottom left, we have a couple different things going on here. And this is that internal thigh rotation. So I guess we could say pictures 1 and 4 are all about freeing the sacrum. Pictures 2 and 3 are all about the internal thigh rotation. The picture on the top right is using a peanut ball, and the peanut ball is between the ankles. We put the peanut ball between the ankles when the baby's low in the pelvis because it causes the thighs to internally rotate. And as you can see from this picture, the provider, or the partner in this case, would be catching the baby from behind. Many providers are not familiar with this, so I would have this conversation with your provider ahead of time to gauge their familiarity with side-lying, pushing, and catching the baby from behind. And then in picture number 3, you have a great shot of me showing you internal thigh rotation in a reclined position. So this is a flat on the back reclined position, so the sacrum does not have movement here. So that would be like a downside. But we have a lot of internal thigh rotation happening here, right? Which is opening that side to side space at the bottom of the pelvis. This is not something that most hospital-based providers are familiar with. When someone is in this position, oftentimes the nurse says, open your leg out, make room for your baby. But in fact, bringing the knees together is what creates that side to side space between the bones of the pelvis. So these are modifications that people could use for recline pushing that take advantage of either internal thigh rotation, sacral freedom, or asymmetry. So we have these, and then we also have those other pushing positions as well. And actually, I'm going to just make a note that I will send these 2 slides in the follow-up email, just so that you can use them like in your own births. I do ask that you do not reproduce these pictures and you do not share them with like clients if you're a birth worker, because I don't have permission from these people for that. But if you want to use them for your own, for your own birth, you can totally do that as examples of like, what positions you might want to try. So let's move on. Let's do a little activity that is going to help us connect our breathing to our pelvic floor function. So if you want to do this one with me now, I urge you to find a comfortable spot to sit. If you want, you can choose a birth ball, or you could choose a hard chair. I'm sitting on a birth ball here. Just something that allows you to really kind of get in touch with your butt. Basically, you're sitting on your butt. You want to be able to feel your butt. We don't feel these muscles quite as easily if we're in a standing position. So if you're able to sit, that's awesome. If not, you can do this activity later on. So I'm going to talk you through this. So what we're going to be doing is focusing on our breath and using our breath to, well, actually allowing our pelvic floor muscles to respond to the way that we breathe. And I think this is a really useful exercise to do in preparation for birth, as well as a useful exercise to share with clients if you're a birth worker. This is a really great way to help people connect with their pelvic floor muscles. I think most people are not very well connected to their pelvic floor. And this is the type of breath that is going to come into play when we are talking about pushing breath or open glottis pushing. So this is something that people can do in preparation for pushing throughout pregnancy. I would say maybe 5 breaths like this per day, which would only take a couple minutes. So it's a really useful way to connect with the pelvic floor, prepare for pushing out the baby, but not invest like hours a day doing that. So we're going to find that firm surface to sit on. Again, I'm on a birth ball. You could be on a hard chair. And you're going to take your hands low on your abdomen. And maybe if you have a big pregnant belly there, maybe you're just supporting your belly gently. If you don't have a big pregnant belly, that's okay too. You can have your hands just low on your belly. And we're going to begin breathing in through the nose, long and slow, and then exhaling out through the mouth. And we'll stay here for 4 more breaths. Inhale through the nose, and then exhale long and slow out through the mouth. We'll do it again. Inhaling through the nose and exhaling long and slow out through the mouth. 2 more times, inhaling through the nose. And if you can focus on even lengthening your exhale, even longer and slower, out through your mouth. And 1 more, in through the nose and longer and slower, out through the mouth. With this next series of breaths, we are going to focus on allowing our rib cages to expand front to back with the inhale. This is where it gets trickier. This is where we are tuning into what's happening in our bodies as we breathe. So I'm going to talk over this breath. So begin inhaling and then continue with your exhale. What we want to focus on is as our lungs fill, feel like your rib cage is pushing outward in the front and then outward in the back. So we'll do this again, inhaling through the nose. As the lungs expand, the rib cage is forced to expand. And then exhaling long and slow out through the mouth. 2 more breaths like this. In through the nose, long and slow, rib cage expands. Exhaling longer and slower out through the mouth. And 1 more breath. In through the nose, long and slow, rib cage expands front to back, making room for all of that breath. And then exhaling out through the mouth. With our next series of breaths, we're going to focus on the pelvic floor muscles. We're going to, and you can keep breathing here, we're going to continue allowing the rib cage to expand, but we're going to recognize that rib cage expansion is only one piece of making space for all that breath. The organs also must move downward. And if the organs are moving downward to create space for all that breath in the lungs, the pelvic floor muscles have no choice but to lengthen in response to that increased breath. And breathe again as I keep talking. The pelvic floor muscles are kind of like a hammock supporting the organs in the pelvic cavity, so the bladder, the uterus, the rectum. But also those pelvic floor muscles are responsible for supporting all of that weight of the torso. So as we inhale, rib cage expands. Focus on allowing the pelvic floor muscles to release and lengthen. And then with your exhale, long and slow, because now there's more room, everything shifts back upward. And we'll do this 2 more times. Inhaling long and slow through the nose, rib cage expands, and then the pelvic floor muscles lengthen as that pressure pushes them down. And then exhaling longer and slower out through the mouth. And one more time. Inhaling long and slow, rib cage expands, pelvic floor muscles lengthen, and then exhaling out through the mouth, longer and slower, letting things come back to a neutral space. This is a really great way to connect the breathing with pelvic floor function. I would absolutely 100% recommend that everyone in pregnancy practice this 5 times per day. 5 breaths, that's it. It's not that much. 5 breaths per day in preparation for giving birth, because getting connected to the pelvic floor muscles will help you push more efficiently, will also help to prevent long-term pelvic floor damage and prevent perineal tearing. So connecting your breath to your pelvic floor function through practice in pregnancy is a great way to preserve the pelvic floor and the perineum. If you are finding that you're doing this exercise and you're like, I don't know where the heck my pelvic floor muscles are, I have a tip for you. Take a dish towel and roll it up. So you have this like cylindrical rolled dish towel, and put it on your hard chair and then sit on it like you're straddling it. It's going to bring a lot of attention to those pelvic floor muscles. So it's almost like it's kind of like in between, almost like it's between the labia, like the labia are resting on that dish towel and like your butt is kind of resting on it. You can wiggle side to side. It feels like you're straddling it. That's what we're aiming for. And so it brings more attention to the pelvic floor. And then when you inhale, you can actually try to press your pelvic floor muscles into that towel. And then when you exhale, allow them to come back. It'll just help you get a little bit more awareness of the pelvic floor muscles. You might not have to do that the entire time. You might do that a few days and then be like, oh, now I know where they are. But this is a really great way to connect breath to pelvic floor function. And use that tip with the rolled towel if you're finding that you're having a hard time figuring out where those pelvic floor muscles are. So this is our little exercise. This is your homework for the coming weeks. So now let's talk a little bit more about what's happening with this abdominal pressure. So I mentioned that as you fill your lungs, that breath is taking up more space. So that means the rib cage has to expand, the organs have to move down, the pelvic floor has to lengthen. So that is an increase in abdominal pressure. When we are pushing babies out, typically we see this a lot in the movies. Somebody is told to take a big deep breath and then hold all that air in and curl down around your baby. And there's people yelling, push, push, push. And there's people going 10, 9, 8, or 1, 2, 3. And the goal, quote unquote goal, is to get to that 10 seconds of pushing with your chin to your chest and your eyes closed and all that pressure pushing down. Wow. Imagine if you had all that pressure on your pelvic floor muscles for 10 seconds, 3 times during one contraction, and you did that for 1 to 3 hours. Wow, what a lot of extra force on the abdominal muscles, or on the pelvic floor muscles. My son just looked in the window. I'm sorry, got distracted. What a heck of a lot of additional force on the pelvic floor muscles. The pelvic floor muscles that are already stretched, that are already partially strained due to the baby coming down. We don't want to make them work harder than they need to, right? Closed glottis, also called Valsalva pushing, is what I just described. That closing closing the throat, closing the nose, allowing that air to stay inside as someone bears down. That's referred to as closed glottis or Valsalva pushing. Research shows that increasing pressure substantially with closed glottis pushing increases the likelihood of prolapse, incontinence, pelvic floor dysfunction, and decreased oxygen to the baby. We see these significant risks involved with closed glottis pushing. I will also point out that most providers are most familiar with closed glottis pushing. They are much less familiar with open glottis pushing. But we'll talk about how to talk about that in just a minute. So closed glottis pushing, big deep breath, chin to the chest, hold that air in and bear down. Increased risk of prolapse, incontinence, pelvic floor dysfunction, and decreased oxygenation. The alternative would be open glottis pushing. Open glottis pushing is taking a big deep breath in, and as you bear down, you allow air to come out. If anyone here is into exercise, you might notice that anytime you are holding a muscle contraction, you should be letting air out. We do not increase the amount of force by holding air in when muscles are contracted. For example, if you want to get up and move with me, you can. So if I was doing something like plie squats, or this isn't really a goddess squat. I'm not a yoga person, so I'm going to get it wrong if I call it a goddess squat. But plie squats, right? So I'm doing something like this. If you want to do this with me, you can, but you don't have to. When I go down, my pelvic floor is lengthening, right? I mean, we can feel that happening. And when I come up, my pelvic floor is contracting. So when my pelvic floor lengthens, I want to be inhaling because my pelvic floor is lengthening. And then when I come back up and my pelvic floor is contracting, I'm exhaling. Inhale, inhale, exhale. We inhale to lengthen, and then we exhale when we allow our muscles to come back into place with a muscular contraction. So we want to apply the same idea to pushing a baby out. We are not holding all this air in as we are bearing down because it will increase the likelihood of pelvic floor issues. So with open glottis pushing, we're bearing down while we're exhaling. So this means that we get protection of the pelvic floor. This protects against prolapse. It decreases the risk of perineal tearing. It decreases the sense of pain during a contraction. But here's the kicker, right? It may lead to longer pushing times. So this is why many providers are not interested in open glottis pushing. Because from a provider standpoint, the faster you can get the baby out, the more time you have to go do other things, right? And, I'm not trying to be like flippant about that, but providers are overworked. We all know that the reproductive healthcare system in this country is not optimal. It doesn't serve the client the way that it should. We know that providers are overworked. We know that hospitals are understaffed. And so if they can just finish one thing and move on to the next, it gives that sense of completion. It's a checking off the to-do list, right? So when we have an option that could lead to a longer pushing time, that's not really desirable. But the research is really showing, and this is from ACOG, which is American College of Obstetricians and Gynecologists, it is showing that it is okay to allow people to have more time for pushing. So the governing organization of obstetricians is now saying, yeah, we need to be a little more flexible with the amount of time that we expect people to push a baby out in. So I hope there will be this bit of trickle down effect from that providers will feel a little less pressure to get babies out quickly. A longer pushing time is not a bad thing as long as laboring person's fine, baby is fine. But from an individual provider standpoint, they don't love a longer pushing time. But if that is the only downside that we're seeing with open glottis pushing, the benefit risk ratio is really something to think about there. So open glottis pushing is supported by research in protecting the pelvic floor and protecting the perineum. And open glottis pushing refers to big deep breath in And then as you're bearing down, you're letting air out rather than holding that air in. And we'll talk in a bit about what's happening with the pelvic floor muscles there too. So open glottis pushing, supported by research, may lead to longer pushing times. ACOG recognizes that is not a bad thing. Now, here's the thing with reluctant providers, right? So we actually have ACOG's statement here. When not coached to breathe in a specific way, people push with an open glottis. So this is like the way that people spontaneously push. In consideration, this is a quote from ACOG. In consideration of the limited data regarding superiority of spontaneous versus Valsalva pushing, and this is obstetrical research, not pelvic floor research. We just looked at pelvic floor research. ACOG is speaking in reference to obstetrical research. Each person should be encouraged to use their preferred and most effective technique. So if obstetrical research says, well, there's not much of a difference, and research on the pelvic floor says there's a huge difference in terms of long-term pelvic floor health, why don't we go with what ACOG is saying, which is let's have people use what feels best to them. And for most people pushing, they're not going to be able to hold their breath for 10 seconds 3 times during one contraction, keeping all that air in. Most people pushing are going to feel that spontaneous or open glottis pushing is working with their body in a way that feels better. That, again, decreases pain. That also helps protect the pelvic floor. So if anyone has a reluctant provider, you can always go back to ACOG and say, you know what, even if you're not interested in checking out the information on the pelvic floor, ACOG says, let me push the way that I want to. And this is from ACOG's bulletin on preventing primary cesarean, I forget what it's called, prevention of the primary cesarean, something along those lines. So if you go to ACOG, type in prevention of the primary cesarean, that bulletin from 2014 will come up. So here we have the difference between spontaneous and directed pushing. So this is a little different. Spontaneous and directed pushing incorporate closed or open glottis pushing. So if we're thinking about it as an umbrella, we have either directed pushing or spontaneous pushing, and then we have closed and open glottis falling into one of those categories. So here you can see the chart that breaks down what's happening with directed versus spontaneous pushing. Directed pushing is that put your chin, take a big deep breath in, put your chin to your chest, and we're going to count while you curl around your baby and bear down. That's directed pushing. Spontaneous pushing is we're going to support you in pushing the way that your body is telling you to, which for many people is kind of like how they push when they're sitting on the toilet. So in terms of the glottis, we see that with directed pushing, people are encouraged to do closed glottis, but with spontaneous pushing, open glottis is the norm. When people are being told how to push, they're told to push for 10 seconds. When people are pushing as their body's telling them to, they push for closer to 5 to 6 seconds. When someone is being told how to push, they bear down 3 times during the length of one contraction. Spontaneous pushing shows that people bear down 2 or 3 times. So 2 or 3 times during one contraction for 5 or 6 seconds versus 3 times during one contraction for 10 seconds. The benefits of that directed pushing is a shorter overall pushing time. We mentioned that. And it's supportive for those that are needing guidance. If somebody does not have enough sensation to feel what they need to in order to push spontaneously, then it makes absolute sense for them to have some guidance. But with spontaneous pushing, as compared to directed pushing, we see increased oxygenation of the baby. We support the long-term health of the pelvic floor and the perineum, and this means we're decreasing the risk of tearing. So there are benefits to spontaneous pushing. There could be benefits possibly to directed pushing. Either of these options are doable with an epidural. Let's say somebody has an epidural and they don't have much sensation. Yes, they can benefit from guidance, but the guidance could be modified to be more like spontaneous pushing, as opposed to the guidance being directed pushing. And yes, we may see that person pushes for a longer amount of time. Is that okay? Well, is the person okay? Is the baby okay? Then that's okay. And if we see that shorter pushing times in terms of the individual bearing down with each contraction, if we recognize that that increases oxygenation of the baby, then we actually see lower risk of distress to the baby when we put in place spontaneous pushing or modify pushing to be more like spontaneous pushing than we do with directed pushing. Research also shows a direct correlation between the amount of time someone spends doing directed pushing and their risk of long-term pelvic floor damage. So this means, let's say, for example, we have somebody who's pushing for 2 hours. So start to finish, they pushed for 2 hours. Let's say an hour and a half of that was spontaneous and a half hour was directed. They are more likely to have better long-term pelvic floor health than somebody who did an hour and a half of directed pushing and only a half hour of spontaneous pushing. So the risk of damage to the pelvic floor is directly related to the amount of time spent pushing in a directed way with closed glottis. Again, food for thought when you're thinking about how you're going to push a baby out or how you're going to support clients in pushing a baby out. So what are we doing when we're pushing? What would be most ideal? How are we actually putting this information into practice? We are allowing the pelvic floor muscles to lengthen. We are recognizing that when we are pushing a baby out, we are not pushing with the pelvic floor muscles. We are pushing with the lower abdominal muscles. We are pushing possibly with the low back. And the star of the show, the uterus, is doing the vast majority of the work with pushing. The pelvic floor muscles, they just need to move out of the way. So we inhale to lengthen those pelvic floor muscles. Remember, we did that with our breath connection activity. We inhale to lengthen, and then we exhale as we bear down. Inhale to lengthen, exhale to bear down. So you can practice this now with me, but again, you can also go back to that exercise and practice it again and again. 5 times a day is my recommendation. So what we would be doing to push in an ideal way for long-term pelvic floor health is to inhale, let our rib cage expand, let the pelvic floor muscles lengthen, and then exhale while keeping the pelvic floor muscles lengthened and using the abdominals to bear down. Inhale, everything expands, pelvic floor muscles lengthen. Rather than actively bringing the pelvic floor muscles back up and contracting them, we exhale and allow them to stay lengthened and use the abdominals to bear down. Where can we practice this? Oh, on the toilet. Not only would I suggest doing those 5 breaths per day that connect you to your pelvic floor, let's take it to the next step and let's practice this type of pushing when we're pooping. Because this type of pushing is not damaging to the pelvic floor. You should not practice directed pushing in pregnancy. Absolutely not. Decreases oxygen flow to the baby. And there's other reasons too, your own well-being. But we do not practice directed pushing when we're pregnant. But you can absolutely practice spontaneous pushing every time you go to the bathroom. You're feeling like, okay, I got to push this poop out. Inhale, let your pelvic floor muscles lengthen, keep them lengthened and do a little bit of a grunt. And then that poop will come out nice and easy. So we can use the same things that we would use to, in a healthy way, pass a bowel movement that we are going to then use also to push our babies out. So I know we're coming up to the end and I promised I would answer some questions, but I just want to kind of give you a little cheat sheet and then our takeaway. So here is our practice pushing cheat sheet. Are we upright? Do we have sacral freedom? Are we connecting our inhale to lengthening of the pelvic floor muscles? Are we using an open glottis? Are we doing shorter pushes? Are we pushing only twice during a contraction? Are we pausing with the ring of fire? I'm going to do a side note here on the ring of fire. The ring of fire is the terrible name given to that stretching of the perineum right before the baby's head comes out. I, again, love to remind people how amazing their bodies are. When the baby's head is about to come out and that ring of fire happens, it feels like a very intense burning sensation in the perineum. Your instinct will be to stop pushing, which is awesome because it protects the pelvic floor and the perineum. If you decided I'm going to barrel right through that, that's not going to be good. That perineum is going to have to split to move out of the way. But instead, sorry for that visual, instead, if we recognize that our body is like, whoa, hold off, the uterus can slowly ease the baby out. And part of our cheat sheet for practical pushing, practice this while you're pooping. Get familiar with the sensation. Use the pelvic floor muscles the way that they are intended. So here's our takeaway. Crash course on pushing. Conventional pushing methods may not be the most ideal options for birthing as they bring risk with limited benefit. I didn't finish that sentence. Understanding spontaneous pushing is important for applying that in both births with and without pain medication. Understanding what kind of makes up spontaneous pushing so that we can use it in all births. Discussion with providers in advance as to how they support physiological pushing can help in both choosing a provider and advocating during birth. If you're 36 weeks in and you're just finding out that your provider is totally unfamiliar with open glottis pushing, all is not lost. You just know now that you have to advocate more actively for that during labor. Pushing spontaneously may be intuitive, but our big thinking brains can often interfere. This is why we create muscle memory through practice. We use this practice in pregnancy with the breath connection activity, with how we're pooping, how we're passing bowel movements. We do this in pregnancy with intention to calm the thinking brain, because then when we do it in labor, the thinking brain's going to be like, oh yeah, I'm totally good with that. Whereas if you're trying for the very first time in labor to spontaneously push with an open glottis, your thinking brain's going to be like, what's going on? This is not what I've seen in the movies every single time, right? We have to create that muscle memory. We have to calm the thinking brain by making it familiar with these things. And this helps to prepare that mind-body connection that's only going to benefit you for pushing out your baby. So, let me just go back here so you can just see if you do want to follow along at any point and gather more information. Here's where you can find me on Facebook, on Instagram, the hashtags that I use. And then, like I mentioned, there's a lot of resources on the website too, free webinars and also low-cost webinars that cover all sorts of different topics. And many of them have guest speakers, not just me talking at you for an hour. So I just want to run through the chat real quick, see what's in there, and see if there are questions that may be just worth answering in the next 5 minutes or so. Hang on one second. There we go. Okay. And then, as I said, I will make sure that we also can answer these questions in the email follow-up. Let's see. I'm just going to run through them real quick. Oh, I love that everybody's sharing all this good stuff. Ooh, love this. Conflicting experiences. Jody says, I would like to buy a flexible pelvis. The place where I would suggest getting the flexible pelvis is Birth International. It's an Australian company. I like supporting them because in my experience, they were one of the first big companies to offer more diverse teaching materials. So I like to get my stuff from them. Let's see. Yeah, so a lot of what I'm seeing in the chat is advocate. How do we advocate for this? How do we advocate for open glottis? How do we advocate for spontaneous pushing? And that's a really good question. I think that's really the bulk of what I saw in the chat, aside from individual experiences. I cannot stress enough prenatally, talking about these things prenatally with your midwife or your OB, seeing where they're at in the spectrum of support for this so that you know how to advocate, so that you know if you have to advocate in the moment. I think it's really helpful to be aware of the research. I mean, in my opinion, it makes a big difference when you can say to an obstetrician, this is actually what ACOG recommends. I think that kind of is meeting them where they're at. Whereas if you're like, I learned it in this workshop from this childbirth educator who owns Blossoming Bellies, they're going to be like, but instead, if you're like, this is what ACOG says, it's going to be, it's going to carry more weight with your average obstetrician. Even though everything I'm sharing here is research-based. But I think that that's helpful, is like kind of gathering your research for things that you might have to advocate for. And in the moment when you're in labor, again, bringing it up before you're at that point where you're pushing, saying to the provider, I'm going to push with an open glottis. This is how I've been practicing pushing. I'm just letting you know. And not saying, are you okay with me doing XYZ? Instead being like, this is what I'm doing. I'm letting you know that I'm going to be doing it. If the person laboring is not in a space, a mental space to use all those words, their support person can, whether it's a birth partner, whether it's a doula, whether it's a friend or a family member. They can make sure that they're talking with their support people ahead of time about what their priorities are and letting their support people be their advocate in labor. And then ultimately, if it comes, one other thing, talk to the nurse. The nurse is the person you're going to see more than anybody else. If you have an awesome nurse on your side, that's going to be someone that can absolutely help you advocate. I tell all my clients to request a nurse familiar with a low intervention birth when they go into triage. If someone's birthing at a birth center, then of course, obviously that's already going to be the case. But birthing in a hospital, I think it's really helpful to have people request that. Then I think at least there's a better chance of having a nurse that is really helpful and helping you kind of remember to advocate for yourself. Ultimately, if it comes down to it in the moment, someone can say, this is what I'm doing. And it can create some tension. It's not the most ideal scenario. But we should also, be working with providers that respect our autonomy in birth. So when making decisions about who to choose to work with, asking these questions really, really early on in the process can be helpful just in choosing a provider. But ultimately, you have the legal right to birth in whatever position you choose. You have the legal right to push however you want to push. For those of you that are birth workers that are like, what do I do if my client said this is a priority and now they're being told they have to be on their back or, whatever. I always love to kind of bring it back to my client and say, are you comfortable like this? This is not what we talked about ahead of time. Or do you want to take 2 more contractions like this and then try all 4s? So bringing it back to the client, I think that models really great behavior for providers too, reminding them that the client is actually the one in control. But then also kind of like voicing without saying to the provider, yeah, she's going to do all 4s next. Instead, you're voicing that like, we've talked about doing all 4s. Do you want to try that soon? And then I think providers have a harder time. They can still obviously be like, no, but they have a harder time saying no when the client has been instrumental in saying, yeah, this is what I want to do next. So you practicing with the language that you're going to use with advocating, talking about these things well in advance with providers, talking about it in labor with providers, getting a really awesome nurse who can also let them know what your priorities are. And in the moment, bringing it back to the client so that that's the person that's in control. And also ultimately, if it comes down to it, being like, this is what I'm doing. And, it is what it is. So thank you guys so much for joining me. Thank you for hanging a little bit longer today. I really appreciate it. I just want to share about the upcoming webinar that we have next month. It is $15, but we have 2 special guests presenting, and it's all about pelvic floor. So it's a nice way to go from pushing into discussion of the pelvic floor postpartum. So we have Amanda Heritage and Rebecca Jones, and I want to make sure I get the title right. They're going to be presenting on after the first 6 weeks, the top 3 overlooked pelvic floor concerns postpartum. So they are both pelvic floor physical therapists. They work together at Breathe Life Physical Therapy, and they're going to be presenting all about commonly overlooked pelvic floor concerns that come up in the postpartum. So that is next month in November. Sign up is on the website if you're interested in that. And again, it will be recorded. So if anyone signs up and can't make it live, the recording will automatically be sent out to you, and you will have access to it for 1 month from the time that it's sent out to you. So I hope you guys will join me again. I'm not sure what I'm going to do in December in terms of a topic for webinars, but stay in touch on social media. I'll definitely post it on there. I'm so glad that you guys like this. Oh, thank you, Corey, about my hair. My hair is getting really long. Yeah, so thank you guys so much for joining me. Thank you for all the awesome information in the chat. I love that you guys were having conversations with each other too. I think that is so important. And I think it's really great to have a mix of birth workers and expectant parents too, so that everybody can kind of connect with each other. So thank you so much. I hope you guys all have a wonderful day and hope to see you again in a future webinar. Bye.